correcting what is deficient in you. And all people have hormone deficiency sooner or later, and I would say sooner than later. And this is what happens. You put the curve more to the right side with hormone sufficiency. You still have to be careful not to do too much, but you just can do more without being burned out. And the body functions better and it's healthier. It's not something that can damage the body by giving hormones, because you correct hormone deficiencies. And so in burnout, the most important hormone deficiency is cortisol deficiency. It's the most frequently found. It's also the one that will make the biggest difference. But cortisol is not enough because there are multiple hormone deficiencies in severe burnout syndromes. So adrenal deficiency is the number one most frequent hormone deficiency in burnout. And many symptoms of burnout are actually cortisol deficiency. And so here, for example, the lack of punch that they have. Cannot get into movement. They don't have the energy. Cortisol stimulates the release of sugar in the blood, so you have more energy. It stimulates ATP production. And there's a lack of fighting spirit, because cortisol is the hormone to fight off, to react to stress. So that may result from cortisol deficiency. Also, these stress feelings that you feel, feeling stressed, because cortisol calms that down. It's the anti-stress hormone. And irritability. Look at this. When you don't have enough cortisol, you have too much adrenaline. And you could get anger outbursts, irritability or anger outbursts. Again, cortisol deficiency.
Otra vez por deficiencia de cortisol. Y esto es muy frecuente en el burnout.
Confusion. Because when there's not enough cortisol, you cannot make connections to your brain. The blood pressure is low and it doesn't work well. You get confused. You don't know what to do. Get overwhelmed by stress. And you also have gastrointestinal problems in burnout, guilt, irritability, aggression, defensiveness, pessimism.
Estar a la defensiva, pesimismo. Todo típico de lo que se encuentra, por ejemplo, signos de la enfermedad de Addison, que es falta de cortisol. Entonces, hay un estudio de 16 mujeres con burnout y lo que vimos comparadas con mujeres sanas, es que 40% menos cortisol urinario, o sea, mucho menos cortisol para encarar el estrés. La vida es demasiado para ellos. La vida es sobrevivirla, pero no es vida. Y esto no pasaría tratado con hormonas. Entonces, esto es la típica curva de cortisol de la persona sana. Durante el día, más cortisol, en particular a la mañana, y después a la tarde, noche, más bajo el cortisol. Este es el pico de la mañana, este es el pico de la tarde, noche, y esto es el nadir a la noche, porque, bueno, baja porque uno tiene que dormir, no necesita cortisol ni energía. Esto es la declinación, reducción diaria durante el día, y hay dos picos para enfrentar situaciones de estrés. Estos son los niveles de maestros.
Jerry, perhaps you are sharing your computer, but we are looking only the last.
Está compartiendo la pantalla, pero no la vemos.
Stop sharing. Okay.
No, dejé de compartir.
Just a moment. I'll
Bien.
share.
Okay.
Ahora voy a compartir de nuevo.
Wait a minute, because
un minutito.
Wine Peak. This is the one I think. Yeah. Share. Is it long time ago that I didn't share my screen?
¿Hace
or is it
mucho
just
que no compartí
recently?
la pantalla o es ahora nomás?
Do I need to go backwards?
¿Tengo que volver hacia
Are you
atrás?
hearing me, Ariel?
¿Me están oyendo, Ariel?
I don't hear you.
Ariel, no te oigo.
From the very beginning,
Desde el principio.
the only thing we saw is the
Lo
last
único que vimos
last
fue la última.
diapo
Do you want me to start
of
again?
your last.
¿Quieren que empiece de nuevo?
Yes, please.
Sí,
I
por
start again or
favor.
I continue?
Por favor. Start again, please.
Okay, sorry.
Disculpen. Okay.
Okay. All right. Okay, now I need to share my screen. Okay.
A ver, voy a compartir la pantalla.
Okay. Is this good for you?
¿Está bien ahora?
Are you hearing me? Okay. Okay. I'll start again, but I'll go a little quicker because apparently
voy a empezar de nuevo, pero voy a ir más rápido porque no vi. Pero les voy a mostrar que mayormente se debe a deficiencia hormonal. Esto es muy frecuente en los médicos y 80% de los, más del 80% sienten que están estresados.
And there are many contributing factors, but among those factors is multiple hormone deficiencies. And you have, for example, all these complaints are complaints of burned out, but you find them also in hormone deficiencies.
Las encontramos también en deficiencias hormonales.
Also work-related, interpersonal
también
are typical of hormone deficits.
Típicas,
and so what happens in burnout is that there's an overproduction of hormones
lo que pasa es que hay una
to face the stress
sobreproducción
and the
de
trauma
hormonas para encarar el estrés, el trauma,
but then
etcétera.
The hormones are overconsumed, and at the end the gland has worked too much,
y la
and
glándula trabaja demasiado.
Ages. And that gives multiple hormone deficiencies that end up in a burned out. You don't know how to treat it. But it's easy because you just correct the hormone deficiency. You see, there are studies showing that there are lower hormone levels in burnout patients. We're going to see that. And there are also studies showing that hormone therapies reverse burnout. They decrease the burnout symptoms. And so you see here this curve where performance of there's a certain stress level, and the higher the stress level is, the less the person will be apt to cope with stress. But basically, this is what you have with hormone deficiencies. You quickly go to end where you get burned out if you don't moderate your activities. Si no moderamos las actividades por el estrés, cuando hacemos terapia hormonal, corremos la curva a la derecha y podemos hacer más antes del burnout. Entonces la terapia hormonal lo puede hacer de manera segura, saludable, mejor performance o desempeño en el pico, pero mayor duración de la resistencia al estrés. La deficiencia más frecuente en el burnout es la de cortisol. Por ejemplo, la falta de punch se debe al bajo nivel de cortisol. No hay azúcar suficiente por el cortisol en sangre. Entonces no puede fabricar ATP con tan bajo nivel de azúcar. También falta espíritu de lucha, que es porque el cortisol es la hormona que la provoca. También hay sensaciones de estrés cuando hay deficiencia de cortisol, más irritabilidad y también brotes de ira. Picos de adrenalina, pero no alcanzan a compensar. Puede haber confusión, problemas gastrointestinales, pesimismo, estar a la defensiva, típicos de deficiencia de cortisol. Estos síntomas de burnout mencionados son típicos y desaparecen cuando se lo administra. Si su estudio dice que mujeres con burnout tenían el cortisol libre en orina 40% más bajo. Es mucho. Fíjense la gráfica, noche, día, noche. Esta gráfica típica nos muestra que hay más a la mañana. Este es el sérico, pico acá. Baja a la tarde, más aún a la noche para dormir. Es tan sencillo como eso. Y eso es lo que no sucede en el paciente con burnout. Debe haber una declinación gradual, pero pequeños picos para enfrentar situaciones de estrés. Esa es una curva sana. En el paciente con burnout, tenemos pacientes con burnout bajo y menores niveles de cortisol, 50% después de dexametasona, acá 20% menos de cortisol en el análisis, 42 pacientes en este caso con burnout con menor cantidad de cortisol sérico, y cuanto más severos serán los niveles, menores serán los niveles de cortisol.
y los niveles picos cortos eran más altos. O sea, no tenían cortisol suficiente para enfrentar las situaciones diarias. Entonces hay una correlación entre el burnout, la deficiencia más grande en burnout, pero no es la única. Estos son militares finlandeses con sobreentrenamiento, burnout. En la segunda mitad del entrenamiento tienen niveles de cortisol sérico muy bajos y no lo pueden incrementar tan bien como antes en el caso del ejercicio. Hay mujeres con abuso sexual y estrés postraumático en comparación con mujeres sin el síndrome post-estrés. Tienen menores niveles de cortisol sérico a la tarde. ¿Qué pasa con los sobrevivientes del Holocausto con estrés postraumático? Uno piensa están libres y está todo bien. No, mantienen el trauma. Muchos tienen estrés postraumático. Y estos son los que tienen niveles de cortisol más bajos en la orina de 24 horas, significativamente inferiores. Y cuanto menor es el contenido del cortisol urinario, mayor el estrés postraumático. También en los veteranos de Vietnam, algunos siguen en guerra.
When they were in the trauma of the fight in the Vietnam. So Vietnam theater veterinarians, about 2,500 those veterinarians, those who had current post-traumatic stress disorder when years later they were examined, had lower morning serum cortisol levels. So they started their day badly. And the more they had been submitted to trauma to combat exposure, the lower the serum cortisol levels were too. And those who were exposed to the highest level of combat and of trauma were also having the lowest levels of cortisol afterwards. So it's not finished when you leave the battleground. You're still suffering at home and being burned out because your cortisol levels are low. And the simple thing of correcting these hormone levels does a lot of good in these patients. I can tell you out of experience. Many studies showing this association. And so what is the treatment if you have to give hydrocortisone? Well, in burned out, he had 9 women who was burned out that received those who had high prolactin burned out patients. That's the one who the prolactin is a stress marker. So the higher it is, the more stressed you are. Well, if you give to those who had high prolactin high prolactin levels, 35 milligrams hydrocortisone, which is a physiological dose. To women, it's 20 to 35 milligrams a dose, generally, or 15 to 35, depending on severity of the deficiency and also on the constitution. If you're small, you need less. Well, it decreased the fatigue, increased the vigor, and also decreased the stress because it decreased the serum prolactin. So it works. And you need to use preferably bidental hydrocortisone, but you have to be careful that the blood pressure is not too high in these patients. And so it decreased the energy and the stress resistance. And for a cortisol deficiency, you can give hydrocortisone. You give it 2 times a day. I give a higher dose often in the morning and a lower dose at lunch. So you give, for example, 15 milligrams in the morning to 10 milligrams in the midday to a woman who's tall. She's not tall as 10 milligrams, 10 at lunch and 10 upon awakening. In men, it's more. It's usually 30 milligrams, 20 in the morning, 10 at midday. I'm an exception. I take everything in the morning, otherwise I forget. So if you have a patient who forgets everything, you can take everything in the morning once a day, and they still can have a lot of energy by this way. But most patients do better when you split the dose in 2. But you need discipline. Always combine it with DHA because DHA counters catabolic effects or adverse effects of cortisol. So if you give about 20 milligrams hydrocortisone, you need to give about 20 milligrams of DHA in general. So really, DHA also protects against any immune suppressive effects of cortisol. So really interesting to do that this way. So now cortisol has to be counterbalanced not only by DHA, that's a major counterbalance, but also other like testosterone, other androgens. Estrogens can also counter any catabolic effect of DHA, growth hormone, melatonin. So be sure there's good balance between catabolic hormone, cortisol, and anabolic hormones. So you can also give prednisolone and methylprednisolone, and actually methylprednisolone is more in patients who have tendency to high blood pressure or to swell up or to get weight gain. So some cases. Usually this is the best for burned out because it gives better psychological effects. Prednisolone is between the two, and then the doses are lower of the synthetic derivatives if ever you give it. But don't forget the DHA. And when you give too much cortisol, you can get agitated, too much energy, you don't want to go to sleep. You can get manic euphoric, you can get insomnia, not sleeping well because you have too much energy, and also insensitive to human suffering. Somebody's dying at your feet and you don't care. You're wondering why this patient is complaining because you feel great. So if you have that, you must decrease the dose by 20 to 25% on average. You can also have cortisol overdose like a moon-like swollen face, weight gain, heartbeats too strongly, hematomas, and ulcers. When you have that, you also have to increase the dose of cortisol at least 20 to 25%. Try to stay in the physiological dose, but some patients need less, you give less. It can also be partly due to the fact that you haven't given enough anabolic hormones to counter the effects. So that's basically what to do with hydrocortisone in burnout. Now, just some short slides about what happens with other hormones of the adrenals. Burnout, low aldosterone levels, can give you the feelings that you have a fainting or empty-headedness. And that is because aldosterone keeps blood pressure keeps salt in the body and water. So if you don't have enough aldosterone, you lose salt and water, you have a low blood pressure. And then these are symptoms of low blood pressure, being drowsy in your head. And this drowsiness, typical that you have. And here's a study, for example, with runners with overtraining syndrome. And you see that they have a lower resting and exercise-related serum aldosterone. Also, persons with post-traumatic stress disorder have high levels of renin, but the aldosterone that should get high doesn't follow. That's also a sign of a weakness of aldosterone production. And so the treatment of that, and you often have to give it with the cortisol and burned out. That's why I'm mentioning it here so important, because if you have cortisol and the person has low aldosterone, you will aggravate the aldosterone deficiency. So often I give fludrocortisone, and the average I give is you add salt, of course. You have to have enough salt, but not too much neither. And you need about 1 gram generally, except if you do a lot of physical activities. Our westernized diet has normally enough salt, but if the person on low salt diet is not adequate when they go on fludrocortisone, they have to drink water. If you don't have salt in water, aldosterone or fludrocortisone, the synthetic derivative, is not going to work. And so the dose that you need to give on average is 100 micrograms per day. You almost can forget all the rest because most patients, whatever their size, do well with that. Some need some higher doses if they still have transient low blood pressure. I have always a little bottle on me, and I have adrenal deficiency, and I take sometimes a little bit higher cortisol level and a little bit higher fludrocortisone when I get in a situation when I have a blood pressure drop like this, for example. So I took a little bit more, ever slightly more, and that can help. So you can transiently also increase the dose, but you have to be careful not to develop, of course, high blood pressure or swollen hands and feet means that you have too much of the fludrocortisone. DHA deficiency can also be there in patients with clinical burnout. They had to do a test where they had to face examinators, like in this picture. And they actually, when they had to do it, when they had burnout, had 43% less DHA in the blood. And also here, there are two types of burnout. There's burnout with high DHA and burnout with low DHA. So you need to do blood tests to know what. They always have low serum cortisol levels, but some can be high serum DHA. And So you see, this is high DHEA levels during the first year, and those, they will have more burned out. So the ones that have high DHEA levels have actually less burnout symptoms during the first year and have a better health because their levels of DHEA stayed. But those who had at the same time low cortisol and low DHEA levels had actually the worst situation, the most burned out. So this shows that DHEA is also a tool for burnout. There's a study that showed that there were no significant differences between DHEA levels and burnout. So it's not the major hormone in burnout, but I would always give some DHEA, except if their DHEA is high already, to patients with burned out when you give cortisol. And I would often give some fludrocortisone, but I check that in 24-hour urine to see if aldosterone is low. And if it is low, I will give it. And it will improve, especially if the blood pressure is low. Okay, so DHEA treatment, if you give it, you have to be careful that it doesn't decrease by increasing the serum DHEA, the ACTH, and then the cortisol production and the serum cortisol. So you risk then the Addison's crisis. It doesn't decrease much the cortisol, but if the cortisol is already very low and then it gets lower, it's not a good situation. So basically, if the patient has cortisol deficiency that is treated, you give about the same dose as you give of cortisol. You give 5 to 30 milligrams DHEA, 20 to 50 milligrams in men. If it's untreated cortisol deficiency, then the dose is 50% lower. And that you have to give because you might aggravate the cortisol deficiency, and that you may not do. So be careful with cortisol, but give it when it's necessary, or give a half dose if it's not the major problem. Avoid overdose. Mainly in women, you have that. You have female pattern hair loss that can come, oily skin, acne, and body hair overgrowth. And sometimes you need to decrease the dose to 5 milligrams to avoid that. But it's often due to estrogen deficiency, but we're going a little too far, and estrogen is protective against these signs in these women. So if you have that, you stop the dose for 2 or 6 months and then go at the half dose, for example. So avoid overdose in women. Mainly in women, you have all these signs, okay? So again, I'm talking about the postgraduate program. Really propose you to follow that. I already explained that, so I'm not going to explain. You also have an offer valid until May 10 if you do it, where you have a special 2 books, like these 2 books, which are the 2 books you need to buy if you really want to start and even specialize in this therapy, because you have most of the information that is practical that you can find, I think, on the topics here, and very well explained with references, all what you need as a physician. So thank you for your attention. I'm sorry for being a bit later. There was some misunderstanding. There was a 3rd presentation to present that I had just presented now. Thank you. Ariel, you're taking it over, I suppose, now? I'm stopped sharing here. Wow.
Thank you, Thierry. I have a few questions, and we have time. It's okay. We are in time. I will read the questions in Spanish.
Okay.
¿Cuánto tiempo se da el cortisol? ¿Cuánto tiempo se da el cortisol y el riesgo de osteoporosis?
How long do you administer cortisol and the risk for osteoporosis?
So the risk of osteoporosis with physiological dose, like for example, 20 milligrams of hydrocortisone in a woman, is only in women in the postmenopause who are not treated with female hormones. If you give higher doses, like for example, synthetic derivative, 5 milligrams of prednisolone or higher, you need absolutely to correct the female hormone deficiencies, or she will get osteoporosis, this patient. You need also to correct the DHEA and androgen deficiencies like testosterone, and then you have a good prevention. I do more because I give growth hormone and other hormones. So I would say that the only dose that you may give to be sure to have no side effects is 15 milligrams hydrocortisone without giving DHEA. Then you won't have osteoporosis, and 2 to 3 milligrams of methylprednisolone or prednisolone, and that's safe. But if you give a physiological dose, you always have to be sure the other hormone deficiencies are corrected, and then there's no osteoporosis. You might still be a little careful. In some patients are very sensitive. So it could be, there's always an exception. So it's good to do a blood scan in that case. But I do it by correcting all the anabolic hormone deficiencies. So I'm much safer by this way. You can also check anyway, if there's muscular atrophy of skin thinning, you're also having a lower bone density. So you already have signs on the body that there's some problem. So you can intervene at that time also. Is there another question?
Sí, perfecto. ¿Cuáles son los valores?
Yes, perfect. What are the normal cortisol values and what is the value below the normal that implies burnout?
So burnout values are at least 20 to 40% lower, but you still can be within the reference rate. For example, if you have the serum cortisol level, it's between 100 and 250 micrograms per deciliter. So the average is the good level, 175, something like that. And if you're below, you're, for example, at 145 or 140 or 120 or below the lower limit, you're too low in generally in cortisol. But I do many tests. I do also 24-hour urines where I check the cortisol level and the metabolites of cortisol, 70-hydroxysteroid. So I have several information at the same time. And but you also values within the reference that are low normal are too low. You have actually in my hormone handbook, if you take my hormone handbook, you have all the levels that are, let's say, optimal and the levels, the range of levels that are deficient. And so if you base yourself on that, you also have information. Don't forget that if you check cortisol in blood, you always have to ask the transporting protein of cortisol, transcortin, because if you have a normal level, but you have a high transcortin, the transcortin keeps bounded the cortisol in blood and there's not so much going in the cells. Okay.
Perfecto. Y el cortisol.
Perfect. We here in Argentina give cortisol early in the morning. No, not give, but extract blood early in the morning and at 4 p.m. Do you do the same thing?
That's a good way. If you only use blood, that's what you have to do. You have to take it in the morning and in the afternoon. And the levels in the afternoon are on the average 2.5 times lower. And that's normal because it goes lower. And you have to do it. But if you do like I do, I take the morning cortisol, so I have the morning peak of cortisol. And I check also cortisol in the urines and the 17-hydroxy metabolites. I have a 24-hour picture. I have enough information. So it depends, but you can, if you only have these tests, do it morning and afternoon.
Bien, acá preguntan sobre la T3.
Question on T3, how to calculate the dose as a function of weight.
I wouldn't calculate the dose on a function of weight. It's true that a person who has more muscles, not more fat, needs more T3. And if you want to treat only with T3, which I do not advise as a first treatment, I would advise to take desiccated thyroid once a day or maybe twice a day, a little bit also before supper. But if you do a T3, you have to start always low, like 5 micrograms. And then you do very often, like for example, the world expert in that is Dennis Wilson. He wrote the workbook on Wilson syndrome. He does it 6 times a day. So you start with 3 times a day, 5 micrograms, and then you go to 6 times a day, 5 micrograms, and then you start building up. And you can start building up to 15, 25. Usually it's 25 micrograms, but I have patients coming to my office 50 micrograms. The problem with T3 is the following, is that many patients, when you know very well the clinical situation, I mean the signs of too much or too low thyroid, they are, when they take the T3, they are 20 minutes later hyperthyroid, they tremble, they are too warm if they have a good dose. And then after 2 hours, they get hypo, they get swollen eyelids, they get some tiredness. And so there is in many patients, if you only give T3, of course, a sort of unstable levels. But if you treat them with hormones that stabilize the binding proteins, like female hormones and testosterone, so you get always the same levels of binding, but you have a better importance. So I always think any treatment of hormones should be given with a full panel of all the hormone deficiencies being correct, and that works better. I'm not sure Ariel is still there. Are you still hearing me? Yeah.
Sí. Yes, yes, we are hearing you. Sí, perfecto.
Yes, we hear you perfectly. Hypothyroidism in cardiovascular risk patients or metabolic syndrome. Should we maintain TSH maximum in 1.5?
So a TSH above 1.3, 1.5, which is the average of a population, is never good. Never good, but there are always exceptions. For weight control, it has been shown that the lower the TSH is, the better it is. Like, for example, if you're below 0.4, which is the lower limit often of the laboratory, it's even better for weight control. But of course, the patient may not show then any signs of hyperthyroidism, being too much overdosed. So that you really have to avoid. And actually, I base my treatment not so much on the TSH because it follows, but on the symptoms and the physical signs and symptoms. If they have no signs of hyperthyroidism or hypothyroidism and no physical signs, I'm happy. If they still have signs of puffiness, I probably need to go to a TSH that is lower and to give more thyroid hormones. But if they're at 1.3 or even 2.0, but you find no problem, then I'm happy too. And I don't go more because the patient looks good. But most patients will have to have a TSH below the 1.3.
Okay. Thierry, thank you very much.
Okay, Thierry, welcome. Thank you.
Thank you, translator.
Sorry.
We continue with you next week.
Yes. I will leave you now and see you next week. And I wanted to ask something. We will have the last session. The last session will be with practical cases. If you want to have a practical case, please, you must send everything to Ariel before Wednesday or Wednesday latest, next Wednesday, not the Wednesday after, because otherwise we won't be able to prepare correctly. Otherwise I will present own cases, but so please send everything to Ariel this week. And if you forget, next week, Monday or Tuesday and latest Wednesday, because we have a lot of holidays here, won't be able to prepare that for you otherwise. Thank you. Thank you for your attention.
Now we have all the questionnaire, so we can send everything perhaps today. Yes. Again to all the people. And okay.
Perfect. I'll leave you now.
See you next week. Thank you again, Thierry. Bye bye. Bueno, nos tomamos 5 minutos y a las 3:10 entonces continuamos con la doctora.
We take 5 minutes and 10 after 3, Leila Boot, and vitamins and hormone treatments. Thank you.
Would let me go. Yeah, 'cause girls like you roll around with guys like me till sundown. When I come through, I need a girl like you, yeah, yeah. Girls like 45. Maybe I'm barely alive. Maybe you're taking my shit for the last time. Yeah. Maybe I know that I'm drunk. Maybe I know you're the one. Maybe I'm thinking it's better if you drive. Oh, 'cause girls like you run around with guys like me till sundown. When I come through, I need a girl like you, yeah.
Not too long ago, I was dancing for dollars. No, it's really real if I let you be my mama. You don't want a girl like me, I'm too crazy. Where every other girl you meet is too gazy. I'm sure them other girls were nice enough, but you need someone to spice it up. So who you gonna call? Cardi, Cardi. Come and rev it up like a Harley, Harley. Why is the best food always forbidden? I'm coming to you now doing 20 over the limit. The red light, stop. I don't play when it comes to my heart, let's get it though. I don't really want a white horse in a carriage. I'm thinking more white horses and carriage. I need you right here, cause every time you fall, I play with this kitty like you play with your guitar.
'Cause girls like you run around with guys like me till sundown. When I come through, I need a girl like you, yeah, yeah. Girls like you love fun, yeah. Me do what I want when I come through. I need a girl like you, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. I need a girl like you, yeah, yeah. Yeah, yeah, yeah. Yeah, yeah, yeah. I need a girl like you. Yeah, yeah, yeah. Yeah, yeah, yeah. I need a girl like you. I got a condo in Manhattan, so gonna get to clapping. Go pop it for a plan, pop it for me. Turn around and drop it for a plan, drop it for me. I'll rent a beach house in Miami. Wake up with no jammies. Lobster tail for dinner. Julio served that scampi. You got it if you want it. Got it if you want it. Said you got it if you want it. Take my wallet if you want it now. Jump in the Cadillac. Girl, let's put some miles on it. Anything you want, just to put a smile on it. You deserve it, baby. You deserve it all. And I'm gonna give it to you. Gold jewelry shining so bright. Strawberry champagne on us. Lucky for you, that's what I like. That's what I like. Lucky for you, that's what I like. That's what I like. Sex by the fire at night. Silk sheets and diamonds, all white. Lucky for you, that's what I like. That's what I like. Lucky for you, that's what I like. That's what I like. I'm talking trips to Puerto Rico. Say the word and we go. You can be my flica. Girl, I'll be a flico, mamacita. I would never make a promise that I can't keep. I promise that your smile ain't gonna never leave. Shopping sprees in Paris. Everything 24 carats. Take a look in that mirror. Now tell me who's
Última parada, entonces.
Last stop, the relevance of vitamins and hormonal functions. Dr. Laila Abbott, also a member of
maneja todo el tema de medicina ortomolecular realmente muy bien, una discípula
She
también
is
de
an able
nuestro querido
disciple of our
doctor
dear
Olsewer y
Dr.
compañía.
Holzauer and company.
Bueno, lo dejo con ellos. Espero
So I leave you with her.
como otro complemento más. Ya
I
análisis ortomolecular. Ahora
think
vamos
it
a
will
ver
be
nutrición.
interesting. Now we're going to focus on vitamins. Next time we will look at nutrition and finally
Todo
the
ayudando a las
intestinal
funciones hormonales.
system
Leila,
in each of hormonal functions.
la
Laila,
bienvenida.
good to have you here. You have the floor. First of all, I would like to thank Ariel for the invitation. It is an honor for me to be here by such important professors as the ones at this conference, which unfortunately is remote. This is not a minor subject, the relevance of vitamins and hormonal functions. As we all know, all vitamins, most of them lipidic vitamins, come from LDL cholesterol. We get progesterone, aldosterone, cortisol, DHEA, testosterone, estradiol, estrone, estriol. And the origin of all this is the LDL cholesterol. For this to work in harmony, LDL needs to be in optimal conditions rather than going through lipidic peroxidation, which is the worst thing that can happen in a patient without hormone replacement therapy or one that is having this therapy, but where radical production is not being controlled. What I'm talking about when I talk about lipidic peroxidation. Lipids are a very important part, or not to say 100%, but very high percentage of cells and of the cell membrane and intracellular components. When there is an increase of free radicals, reactive oxygen species, as explained very well by Pablo in the previous class, in excess of the antioxidant capacity of cells, there is a rupture of LDL, and that is called lipidic peroxidation, which is understandable. The most important radical acting here is the oxidryl radical, the most deleterious of them all. And to make things worse, there is no endogenous system against it. There are systems to defend from hydrogen peroxide and transition metals released together with hydrogen peroxide, but there is nothing for the oxidryl in the internal arena. This will inhibit the LDL oxidation in our molecular medicine. We do not use unlike formulations, but we work on compounding adapted to the patient. How do we inhibit LDL oxidation? Tocopherol, ascorbic acid, doses from 250 milligrams to 1 gram, beta carotene 15 to 100 milligrams, lycopene, coenzyme Q10, and flavonoids. Looking at papers, you always look at papers, multicentric studies, etc. What happens with the oxidative profile of women in the menopause, the role of estrogens to prevent and treat disease? Of course, this paper highlights not just the fact that estrogens are completely antioxidant, but also that they have the capacity of increasing the endogenous antioxidant system, as I said at the beginning. The estrogens that we administer, the bioidentical estrogen and the patient's estrogen, will have the capacity to stimulate the formation of superoxide dismutase in the mitochondria and in the cytoplasm. And on the other hand, there will be an assistance and a driving force in the formation of glutathione as an antioxidant as well. Sometimes this doesn't quite work. Let's go to tocopherol here, or vitamin E, which I believe is the most important together with vitamin C in inhibiting lipid peroxidation. It recovers the glutathione peroxidase, it is part of cell membranes. We should not forget that vitamin E is a liposoluble vitamin. It is part of apolipoproteins A. Daily doses are some 200 IUs. And with higher doses, you need to be careful, especially with obese patients, such as Dr. Thierry said, or metabolic syndrome, because that accumulation of vitamin E can become a pro-oxidating factor. Look at this article that I found, and let me share this with you because it caught my eye. What happens with vitamin E in the menopause? Dates back to 1949. I had not been born by that date, luckily. And this trial looked at many patients and decided that supplementation with vitamin E improved a lot based on motor symptoms in menopause patients, breast pain or flush, hot flushes, but also in the vaginal tissue smears, the oral vitamin E had a change, caused a change in the vagina smear. This other paper from it's a review, I'm so sorry, nutraceuticals review is not just about vitamins a patient needs to have who are subject to hormonal replacement therapy. In the articles that you can access more easily, such as PubMed, you will see many articles on synthetic therapy rather than bioidenticals. But as to perimenopausal or menopausal patients or patients in andropause, even when they are not getting any HRT, these nutraceuticals are important to palliate the lipidic peroxidation and also be able to fight a radical that is so deleterious against the cellular membrane and also the patient's hormones. What happens with vitamin E, supplementation, and the mitochondria, and we go back to this. Vitamin E is not just part of the mitochondrial component, but it's also very important for the formation of a primary antioxidating system in the cell. Now let's move on to vitamin C. As we all know, is the first line of action in oxidative radical inhibition, which we said has no endogenous defense system. It boosts the impacts of other antioxidants. That's why by its own it may not be useful. It prevents LDL oxidation. It rebuilds vitamin E and beta carotene. Remember that vitamin E can oxidize, so I need to antioxidize it by administering vitamin C. It is involved in the formation of nitric oxide, which is so important for microvessels. And further on, I'm going to share with you a paper. You will be able to have it available in relation to this and penis dysfunction. The basic dose is 250 to 500 milligrams. In orthomolecular medicine, we titrate it and get to the dose that the patient needs and can tolerate. But in order to do that, there is a course of orthomolecular medicine to attend. This is another paper that deals with the relevance of vitamin C in the brain. It can be concentrated in the brain. It is important for the formation of neurotransmitters. They are vitamins, meaning vital aminos. So you cannot do away with them or do without them for the hormonal formation, not just for the oxidative part. It's they're involved in neurohormone formation and hormone formation as well. There's another review on vitamin C in the treatment and or prevention of obesity, as I said before. But not just talking about vitamin C as a hormonal precursor, but also that vitamin C will have an impact, big impact on adipocytes, causing lipolysis of the adipocyte itself, thus helping, and we will see later, that to help vitamin D not to become a peroxidating factor in a patient who is obese or has metabolic syndrome. This is another paper on vitamin C as an essential stress hormone during sepsis. But the paper itself is more involved in the relevance of vitamin C in cortisol synthesis, catecholamine synthesis, as Dr. Thierry said today, when the patient is going through burnout stage, so to say, or adrenal stress phase 3 or 4, as we call this in orthomolecular medicine, the relevance of the patient, because there will be a lot of depletion of vitamin C in this kind of patients, and so it's a sine qua non condition to administer oral vitamin C as a supplement. Vitamin D. Vitamin D. My friends always kid with me because I say it's not a vitamin, but a hormone. So it will be important in regulating the phosphocalcium metabolism, but also it is a hormone that is present in anything associated to cell differentiation, immunity, when there are papers that deal with diabetes type 1, where vitamin D, when it is lacking, there is an excess of T cells, which have an impact on the pancreas cells in a diabetes type 2. It will be associated going from pro-insulin to insulin. And if we don't have it, there will be a lack of calcium for this to take place in the pancreas beta cells. It regulates blood pressure. This is known from vitamin D or hormones. It helps regulate and helps manage the renin, angiotensin, aldosterone system, also associated to cancer. The optimum vitamin D levels or hormone have to be over 70 nanograms per deciliter to prevent mostly breast and uterus cancer or cancer at large. As to autoimmune diseases, D hormone has a major role in regulating the immune system cells. Same thing happens with neurodegenerative diseases. The dose will be based on the clinical conditions. This is what I do. I order blood work to check the dose at that time, and up to 10 milligrams is a lack, 20 milligrams insufficiency, and it should be over 30 nanograms per deciliter. I typically want them to be over 60. When the patient has lack, there is a load dose that can be done through this calculation, 40 times 75 minus the D3 25-hydroxypacifferol in blood times the weight of the patient, and this will give us the next number of units that can be administered once a day, typically with food because it is a liposoluble hormone, or else into deferred intakes 1 week apart. It will be a genomic and a non-genomic path of action. The non-genomics it takes place in seconds or minutes and will act through calcium channels. It is seen a lot in liver, viscera, parotid gland, kidney. It's in seconds or minutes. And the genomic, the most important pathway, It will be shared but with the other hormones such as estrogens and testosterone. It is the nuclear receptor pathway, which binds to a retinoid receptor, causing its action through the stimulation of the transcription of over 900 genes. That is the 125 hydroxycalciferol hormone. The first activation of the D hormone that will cause an activation
oxidación en el carbono 25 y la segunda y más importante, que es la que le va a dar la
and the most important one and the one that will provide its activity in the kidney, where the carboxylation will take place in carbon 1. That's what it's called 125 hydroxy vitamin D. And this conversion will be stimulated by estrogens, parathormone, inhibited by the 125 hydroxy vitamin D, and blocked by the 124 vitamin D, which is what I was telling you before about metabolic syndrome patients and hypothyroid patients, who will also have a great capacity of oxidating these hormones, because hypothyroid patients manufacture by a low quantity the superoxide dismutase, and apart from that, it is too slow. This talks about the relevance of not having T3 deficiency in the peri-puberty area, because it can bring trouble at the time of the first menstruation, because there can be a decrease in oocyte production, deficiency in uterine maturation, ciliary movement, fallopian tubes, all of this because of vitamin D deficiency in puberty. As I said before, the relevance of vitamin D and male erectile function, when we talk about an anti-inflammatory impact of vitamin D in the microvascular system. That is why it's not only support as to testosterone, oxytocin, to support a fuller sexual life, but also we need to look at vitamin D levels in patients. This is the Nutrients magazine, which deals with what I said before about hormone D in Crohn's disease, inflammatory bowel disease, colon cancer, breast cancer. Hormone D has an anti-proliferative and anti-angiogenic activity. Then we have inositol, also called vitamin B8. It is very important for the regulation of the menstrual cycle, stimulates ovulation, decreases the appearance of polycystic ovary symptoms. There are many papers now that support micronized progesterone, inositol, and vitamin D to deal with PCO and its symptoms, decreases acne and bodily hair, together with other medications. It improves sperm quality, thyroid function, and the daily dose is 250 milligrams, more or less. There's another paper. I typically show papers that support what we say, because these are RCTs, and typically it's good to have supporting material for what we are saying. Vitamins P. Vitamins P is what we call citroflavonoids, components of fruits, mostly orange and red. They are non-nitrogenated plant chemicals present in citric fruit. The most common ones are quercetin, lutein, diosmin, naringin, which strengthen vessel walls. That's why it's very important in patients with metabolic syndrome, diabetes, or erectile dysfunction. They have a great oxidative power, promotes vitamin C absorption, decrease cholesterol, the LDL, but it provides a good performance, helps anti-oxidation, especially in people with metabolic syndrome. As I said before, as vessel walls are strengthened, they are called vitamin P because they increase permeability. They are anti-inflammatory and improve liver function a lot. This will be discussed later when we talk about liver function for hormone detoxification and to prevent any hazard there. The relevance of vitamin P will be seen there. Vitamin K, especially K1 and K2, the ones that take calcium to the bones rather than being deposited in some major artery. Can be synthesized by the large intestine. That is why the coagulation stimulates the formation of calcium chelate, and you can administer up to 2 milligrams per day associated to vitamin D. Vitamin complex B, very important to hormonal formation. It depends a lot on the intestine of our patients. That's why we need to check on intestinal hyperpermeability. This has been discussed in the course, especially B1. It is part of over 50 enzymes. It is critical for the for growth and reproduction, skin and hair. Also, it is involved in the acetylcholine synthesis. Vitamin B2 acts on the mitochondria. It is a component of flavoproteins forming ATP. It needs are increasing hyperthyroidism, stress, and poor malabsorption. It is depleted by boron. That we need to be careful when we administer boron in osteoporosis. There are many papers that we administer boron magnesium to menopausal patients 3 milligrams a day, and that improves the performance of osteoporotic patients. But we need to be very careful in the use of boron and vitamin B2. Vitamin B3 is nicotinamide. It is nicotinic acid and niacinamide. It is active in the body as NAD and NADP, very important for the electron chain. It acts in the metabolism of carbohydrates, proteins, and lipids, mostly the symbol and cellular metabolism. It is essential for hormonal synthesis of any hormone, repairs and protects genetic material. This is very important because if the genetic material is not on top of the game, it cannot act. The retinoid receptor and B3 cannot act for the maturation and synthesis of hormones. It's a major cofactor in dopamine synthesis, and the daily dose is 40 to 500 milligrams a day.
Acá hay otra revisión bibliográfica de los aspectos esenciales de la niacina.
These are essential aspects of niacin. I will leave this with Ariel so that he can share it with all of you. B5 is relevant in the creation of cortisol and corticosteroids. It's part of the acetyltransferase choline and precursor of all steroid hormones. It acts in the porphyrin synthesis and in the synthesis of fatty acids, and the necessary dose is this, of course, is patient dependent. It's not a fixed doses, but it would be between 50 to 100 milligrams a day. B6, active in the liver, it's an essential coenzyme for carbohydrates and lipid synthesis, metabolism. It participates in hormonal synthesis, in repairing genetic material. Tryptophan requires B3 and B6 to become serotonin. It participates in the synthesis of dopamine, epinephrine, taurine, and GABA, and pyridoxine, as when the synthesis is the doses is 5 to 300 milligrams a day. We have to bear this in mind when we want to optimize mitochondrial function and lipidic synthesis, as well as genetic material. B7, very important, it's biotin, present for growth of hair, and in its lack is the most important reason for hair deficit. Participates in the synthesis of ARN and ADN and hair growth. Dysbiosis is a reason for its deficit. Dose from 100 to 400 milligrams a day. B9, which is called folic acid, participates in DNA formation, preventing its lack. It has to do with what happens in pregnancy, depression, alcoholism. It's important in alcoholic liver, in anemia, in plasma homocysteine. It's important for reperfusion and ischemia, and it comes in raw foods, 200 milligrams to 2 milligrams per day. B12. It's an essential coenzyme in the protein and carbohydrate and lipids metabolism. It has to do with the metabolism or synthesis of nucleic bases, acts on peripheral nerves at the level of the nucleus of cells and peripheral cells, on the central nervous system, on the red and white blood cells generation, and it's 50 to 200 micrograms per day. That's the dose. And this paper regarding antioxidant vitamins and those that have to do with homocysteine metabolism in menopausal women, this explains what I commented before. We can give our patients a replacement treatment, hormone replacement treatment, which may be synthetic or not, through the diet. A lot of parameters will improve and there will be fewer risks. But with the synthetic ones, vasomotor symptoms, for example, may be improved as well. What is worse is the homocysteine blood increase, and this causes cardiovascular problems. So a menopausal or perimenopausal woman, we have to check homocysteine because that will be connected with B1, B6, and folic acid levels. Carotenes have a significant function in blocking the singlet oxygen caused by UV radiation. All carotenes are antioxidants. The best one is lycopene, which stimulates proliferation and differentiation of cells. It maintains normal thyroid levels. Vitamin A, for example, maintains in a Hashimoto thyroiditis, keeps the gland within normal sizes so that it won't keep growing. And vitamin D will decrease the antiperoxidase antibodies as well. Carotenes working on the thyroid size is particular lycopenes and lycopenes in the tomato, for example. And vitamin A D, vitamin C, zinc, and thyroid hormones are regulated thanks to it. Lycopene is very important. Tomato, it's a liposoluble pigment. It's the cis isomer, which is the most important one we have to eat. It protects lipids, proteins, and DNA from oxidative damage, inhibits proliferation of cancer cells. It is directly associated to connexin 43, which has to do with breast cells. The protein is stimulated by lycopene. So if two cells are too close, that inhibits their growth. Therefore, lycopene inhibits that from happening. It reduces cell proliferation. It modulates cholesterol, protects the skin. Dose 5 to 15 milligrams a day. This, as I said before, the paper on oxidative stress in female reproduction. I talked about this before, how important it is to stop free radicals so as to control oxidative stress in women in fertile age, because it makes for an immature oocyte. It slows down ciliary movement in the fallopian tubes, and for men, it changes the quality of sperm and reduces the erection of the penis. And let me add one more, which is coenzyme Q10. It's not a vitamin, but it is of major importance in the inhibition of lipidic oxidation. It is essential in the mitochondrial membrane. It slows down the aging process. Women have less Q10 than men, and it modulates insulin resistance. And it's 30 milligrams approximately. That's the dose. This is what I commented before. It's an old paper, 2013, but it talks about nutritional requirements in patients on oral contraception. And it's very interesting because younger women get contraception without, young women get contraception without really measuring vitamin levels, what the GI tract is, in what status it is. And in this paper, it's shown that women on contraceptives have antioxidant vitamins in very low levels. Thank you very much. And if you have any questions, with pleasure. Thank you, Leila. Excellent presentation. I always say in a very holistic fashion. Yeah, we have to correct my camera because I've been shortened, decapitated. There we go. A holistic approach. I always talk about that. I was thinking that what we are talking about, it's like an orchestra. Hormones are definitely, but there's also a number of instruments around the orchestra that are not necessarily visible. There's drums and trumpets that are not present first line. The first line is usually violins or piano, and those would be hormones. But what Pablo said the other day and what you are saying today and will be said by Florencia and the doctor from Spain complete the symphony of our orchestra. And we have only a couple of questions. Is it possible to get the vitamins we need with our food and lifestyle? It's a very good question. I would love to be able to say yes. I always laugh with Adolfo Cordonier. He's a doctor who's a fan of lifestyle and diet. Of course, I am too, but I disagree gently with him because foodstuffs do not necessarily have enough oligoelements and vitamins, enough of them for our metabolism, hormonal or whatever, to work the way they have to work. If my patient comes um, and says, I smoke, I don't exercise, I love sweets. Of course, I cannot expect that by giving her cauliflower, broccoli, and fruits, she'll be antioxidated within the next week. And then I'll give her a bioidentical hormone. And most probably the patient won't do well with that. So I am responsible to say that foodstuffs, at least at the beginning of a hormonal treatment, are not enough. Do you dose of vitamin E and C in your patients, or do you just give it clinically? When I was young, many years ago, I would dose. I still dose vitamin D, but vitamin E. But depending on patient habits, on the questionnaire, on lifestyles and diet, whether there's stress or not, if she runs, um, all extremes are not good, any extreme. So, I draw blood, and then based on that, I formulate. There are a lot of people present here today who are gynecologists, and they are only just beginning to think of orthomolecular medicine. And so they ask, is there a supplement that may be generically indicated for patients? For example, the anti-age vaccine. I know the answer, of course, but I would like to hear yours. The ideal thing would be having a basic formula. We're all physicians here. I'm not a gynecologist. I would have liked, but then I went for aesthetic medicine. When we talked about LDL oxidation, that's a great antioxidant formula. We can add vitamin C and E and acetylcysteine. I'm sure Pablo talked about this, and Flor will, because it's very important, and alpha lipoic acid, etc. Those are basic tools for our patients, but it's not like a recipe that we can just offer. We have to titer vitamin C, and certain patients require more than 4 milligrams of oral vitamin C. But yes, there is a general formula. I showed it to you in my PowerPoint. Of course, this is going to uh, it's going to be downloaded in the internet, so you can check this again if you like. What about supplementation with statins and vitamin D? Statins, a patient who has hypercholesterol and hyperlipidemia, there's a metabolic syndrome there, and that is because of a lack of vitamin D. And if the patient has a metabolic syndrome on statins, obviously he needs to be antioxidated. Statins inhibit the co-reductase HMG, so we need to help that liver, which is going to be bothered by statins. I need to help it with antioxidants, in particular to detoxify the liver. Vitamins for patients on contraception or on replacement therapy. What vitamins? dose, 25-hydroxyvitamin D, homocysteine. We know that if homocysteine is high, the patient is going to have low B1, B6, folic acid, B12. So I can ask for ascorbic acid levels. Of course, yes, but with this and the clinical information of the patient, I will know. In particular, patients with hyperpermeable guts, if your belly is swollen, you will know that. Adrenal burnout. B5, is it useful? Yes, of course. And C as well. Very good. Now we will call it quits. But before that, a comment for our non-Argentine audience. You may have seen that this event is being sponsored by Biopel Concept. Biopel Concept is what we have been applying in Argentina for hormonal treatments, creams and pellets. And that is available if you wish to develop this technique in Latin America. So please contact us if you're interested, and we'll see how to help you out to implement these treatments in your own countries. Just write to us and we will answer. Thank you, Leila. I loved your presentation. It contributes to our idea that when I thought this event out, I thought of something holistic. Hormones, yes, but all that is around hormones as well, like vitamins. Thank you very much, and we'll meet again next week. If you wish to register for the last presentation, Dr. Herzog, please let us know. We will send you all of the info. There are a couple of persons that have registered already. There is only room for 4, and 2 have already registered, so hurry up. And I want to have time for the Q&A. We need to leave time for our Spanish guest as well after Dr. Thierry's presentation. So greetings to all. Have a great weekend and see you next week. Bye.
Lucky for you, that's what I like. That's what I like. Sex by the fire at night. Silk sheets and diamonds, all white. Lucky for you, that's what I like. That's what I like. Lucky for you, that's what I like. That's what I like. You say you want a good time. Me say yeah.
Come up to meet you, tell you I'm sorry.